Let's look into another point of the business of the day. Dr. Ouma Oluga is the Principal Secretary Medical Services at the Ministry of Health, and he joins us in the hot seat this morning. Daktari.
Hi.
Hey, Daktari, good morning.
Good morning. How are you?
I am well, thank you.
Yes, I'm well too. Thank you.
You're
good
well?
to see you.
Good to see you too.
Yeah, and good to see you, Dennis.
Good to see you.
Karibu sana.
Asanteni sana.
Thank you for finally making it into the hot seat. There are a number of issues that we would like to look into, and so we're glad that you did this with us this morning, because Kenyans have questions, and you are in a unique position to answer some of those. But let's get into it first, because Dennis wants to welcome you with today's proverb, and we'd love to get your interpretation.
Yes, and the proverb today comes from Yoruba. The Yoruba people of Nigeria.
Why are you looking at me?
Are you Yoruba?
I'm
No,
not-
he has pointed at you.
Okay.
It's her
I'm
neighbors.
not Yoruba,
Her
actually,
neighbors.
but yeah.
Yeah, and the Yoruba people are saying, where you sit when you are old reveals where you stood when you were young.
Very true. Yeah, they say that there's a lot of sight that comes with being old. You've seen enough to be tall, even when you are seated. I think so. I think that's the closest interpretation, that the senior and elderly people have seen enough that when they sit, they may be still taller than those of us that are standing. While young. But I think maybe it can also be inferred to mean that you need to plan early, so that you determine where you will sit
Yeah.
in the later days.
True.
True.
Well said, well put.
Very, very much so. And as you said that, and then leading into our conversation, I was watching you, and I remember that we've had conversations with you in this room when you were at the unions,
Yes.
and then when you were at the NMS, and then here we are at the Ministry of Health. So looking at that. I guess at the point where you are now is a consummate sum of all of those different experiences, which hopefully is helping you do what you need to do today.
I thank God for that.
It's interesting. But let's look at a number of things at this point that are filling the Kenyan headspace in terms of health. And one of the things that's really big on the agenda is the most current deal that was signed between the country and the United States, all in the face of what the health situation looks like. So we'll paint a few brushstrokes. Number one, we know that with the most recent relinquishing of health-based funding from the US, that meant that Kenya was going to be put in limbo over certain things, as other countries were.
Yeah.
And we also see that under Shah, that there have been complaints over and over and over again about the state of the working operations of the Social Health Authority. So very many things seem to be up in the air. It looks as though that this health funding then would be a panacea to all of this. Is this the case?
Very much the case, and I like using. It's long since I had the word panacea, but exactly that is what it is. And thank you, Ndu, for painting that picture. So two things that are very important for us to understand is that health is one of the priority agenda for this government, and there is the 5 key pillars of how we want to transform the lives and the economy of the country and of the people. And these 5 key pillars, so housing and settlement, you've heard the president talk about housing all the time and settlements. There is the whole issue about economy in terms of jobs, businesses, so the SMEs, the MSMEs. Then there is the digitization and the creative economy, and of course you've seen the G2MES and the internet being put everywhere. That's the third. Then of course there is agriculture and food security, and then health. I think what we need to understand, what it means, health as a pillar of transforming the economy and the lives of the people. And again, two things are here. Number one is that health shouldn't be what makes you poor when you are seeking it. That health shouldn't be what makes you poor. But number two is that the activities within the health space should also drive our economic growth. And so you can unbundle both. So number one is that health shouldn't be what makes a family to be orphaned, then they can't pay school fee because their father or mother or breadwinner had to die because they can't access a surgery. And so if you do the total sum, that's exactly what we are doing. And then number two is that the way we are doing these things should also be in itself be an economic driver. Now, coming to the nitty-gritties of healthcare itself, we have 4 key priority areas within healthcare. One of them is the healthcare financing. Because without money, you cannot finance what is important. You have to get the money.
Yes.
So we have been so keen on what we call domestic resource mobilization. And that's where the SHA story comes in. Because it's a way of ourselves putting in money in our basket so that we can pay for healthcare. Because for you to stop people from dying because of health, you must give them an opportunity or a mechanism of paying for that health,
Yes.
so that they don't die,
Yes.
or so that they don't get poor while seeking healthcare. So in the Social Health Authority, there are actually 2 ways in which we mobilize for resources. One is through the taxes. So through the taxes, of course, we ask Parliament to appropriate money, and we have there 2 funds, what we call the Primary Healthcare Fund and then the Emergency Chronic and Critical Illness Fund. And then this whole health financing means that you should also choose what am I paying for, and is it so important that if I don't pay for it, this person will die or they'll get very poor. And I'll give you a very good example of dialysis. It costs around 1.1 million shillings to have dialysis done for 1 year. Now, for many Kenyans, whether you're working, whether you're employed, like most of us were employed, if you are to pay for 1.1 million shillings, you will get poor. Your salary can't afford it. So either you will have to forgo paying school fee for your child or doing some other economic activity that is important, or you will die because you can't afford it. So that's why the government is paying for it, and we spend a lot of money there. The same with issues around cancer, where we now spend around 800,000 per patient in a year, because many families, they'll go bankrupt if they have to pay for it. The same with things like accidents, where we, for the first 24 hours, we do it. Now, but then there are, of course, the other mechanism, which is the contributions of the people. So if you're employed like all of us here, at least you see something from your pay slip, so you to contribute. If you're in business, we have mechanisms to get people in. The second priority, of course, is the health workforce. The health workforce is the bloodstream of the healthcare system. Without the health workers, you cannot deliver services. So we have been very keen to make sure that it's a key agenda in terms of the UHC delivery model. The third is health commodities. So the availability of drugs, the availability of equipment. There we have several programs. One of them is the reforms in KEMSA to make sure that hii ugonjwa ya hakuna dawa is no longer there, because and we found only 38% of medicines that patients required were available. Now it's all the way to 70%. In the last 6 months, we've made it 70%, but we are going towards 98% by March next year. Of course, His Excellency the President has given us a deadline of January, and then we are really pushing to make sure that at all hospitals we have medicines. And then there is also the whole issue about manufacturing locally to make sure that we are resilient. And then we are now providing equipment in hospitals through the National Equipment Service Program. And the last is digitization, so that we make sure all of these things are tied together. We have enough data, and I know we are going to talk about that. We have enough data so that our healthcare system is based on truth. And that truth is from a single source, so that you are not arguing with me where that truth is coming from. It's about all the actions being recorded, being unified, and we all know that that is the source of this data. And that is why we are doing digitization, so that when the patient goes, we know who the patient is. That we have an identifier for the patient. We have an identifier for the provider, that's the hospital. We have an identifier for the professional, the doctor, the nurse, the clinical officer. And we have an identifier for the product, whether you used an X-ray or a medicine, we can identify you throughout.
Across board.
Across board.
All
So
right.
that's the picture of the agenda that we are pursuing. And so far, we have to be grateful to Kenyans. 27.9 million. Actually, we are 12,000 to 28 million. I think by 10 a.m. this morning, we will be 28 million Kenyans that have already registered and are enjoying the services of the Social Health Authority. We have had a number of breakthroughs with hospitals. You've seen equipping of new hospitals in the last State of the Nation address. His Excellency addressed this, and it was fact-checked to be true in terms of the model that we are using to make sure that all our hospitals have modern X-rays, modern CT scans, modern cancer machines. And we are also working very hard to solve all issues of health workers. I think you've seen the UHC now is down. There is no other strikes. The doctors are enjoying their arrears. The nurses, we just solved all their issues. So we are working very well. But all of these things require resources. And part of that resource needs us to mobilize. And so as much as this is a priority of the government, and we've really been pushing Kenyans, and Kenyans have been responding very well with us, we are also looking at how can we achieve it faster. And that is where the US-Kenya government
deal comes in. All right.
Because it's part and parcel of the actions to mobilize enough resources so that we get there faster.
So, Dr. the deal that we talk about, US and Kenya, one of the contentious issues that does exist here is the money is, we need that, right? But there is the aspect of the data sharing that does exist. And Kenyans are concerned in terms of, why are we sharing our data with a foreign country? That's number one. Number two, there is also the aspect of participation. Kenyans also want to have a voice on decisions when it comes to their information, right? And there is also the aspect of, if we are sharing data, can they also share their data with us? Or is it one-sided? Because these are questions that are being raised, and perhaps it's an opportunity for you to clear the air. You know, are we sharing our data with the United States in terms of the data privacy? Was the agency involved? Where are we with that?
Yeah, thank you so much for this question. And this is something I think we will have to keep answering. And I think Kenyans shouldn't get tired of asking that question. I think I wanted to clarify that. We are not tired of clarifying it, and we will never get tired of clarifying it. Our foremost job as public officers, from an accountability perspective, is to be transparent and to carry Kenyans along. So, so the data sharing agreement comes from the bigger framework. So the bigger framework talks about the things that we want to do together. And there are a number of areas. There were 6 areas in that framework that are important. How we want to deal with outbreaks and how we want to deal with surveillance of disease, which is a very important thing that every country must do. Number 2, how we want to support delivery of services, so the health workforce again comes in. Number 3 is how we want to deal with commodities, how we want to avail the ARVs, the malaria medicines, the nets that we use, the laboratory equipment and all that. Number 4 is how we deal with maternal and child health issues. That's one of the biggest things around here. Number 5, of course, is the issues that relate to strategic investments, particularly the areas that we want to invest in around our priorities, the ones that I've mentioned, the social insurance revenue mechanisms, issues that relate to how the system performs when you go to a hospital, the waiting times and all that, how we want to jiggle the system to work better for the Kenyans. And the last one, of course, is the program management and the whole performance and monitoring and reporting issues. So now all those things will produce data. So, for example, if I sign together with you that we are going to support surveillance of outbreaks of disease. Let's say right now we have Marburg that the government of Ethiopia has declared, and we are surveilling how we want to protect Kenya or whether there is any case of Marburg in Kenya, the virus. All of that require data, right? Now, when we use that data and somebody else is supporting you, it is just fair that I show you what I've done. If you give me money to survey a disease, it is important that I show you this is what I did.
Okay.
But I'm not showing you that Dennis or Oluga or Ndu had Marburg. No. What I'm showing you is that, oh, by the way, I set up this border screening in Namanga or in Manda or in this port, and out of 200 people that I screened, 10 of them had Marburg.
So what you're saying, that, sorry, just for clarity.
So, and that is what we are calling aggregate data.
Okay.
And that is what we are calling the identified data.
Allow me to clarify.
Yeah.
What you're saying is not somebody in this case, the US is giving money to Kenya to the amount of $1.6 billion US.
208 billion Kenya shillings.
Right?
Yeah, and I think that is important.
It's very important.
That's the largest, it's the single most...
it's the highest amount of money that has been given to Kenya in terms of medical
and
funding.
it's a big deal.
It's a big deal.
For us, a big deal, yeah.
But on the other side of it, what we're saying here is that as this money is being given to Kenya, that the US then is basically saying, just tell us what you did with it. Accounting and management and accountability, right?
And in fact...
Okay, now if that's the case, why is there a time frame on it until a certain period of time? I think the time frame is a number of decades, isn't it? Why have that information in public, in the US record for a period of time? I mean, 286 billion shillings is probably going to be utilized really quickly in Kenya for the different demands which you have put out this morning.
Yeah.
That will be used. But why would this information then remain with the US for 25 years?
No. The information is not remaining in the US for 25 years. So first of all, for the record, we have made all these documents public. I think our cabinet secretary shared. I had mentioned yesterday in the morning that we were still doing some institutionalization, which got finished in the day, and we made all the documents public. So even as I speak right now, a Kenyan can go, read, and ask me a question. So I think that is how transparent we are. And yes, the cooperation framework is for a period of 5 years. You mentioned something very important. So there was where we are coming from. Where we are coming from is that there is what we call dwindling donor support. So many donors are withdrawing, including the US. So let's not be mistaken. Including the US.
They were one of the first.
So they were one of the first to withdraw. And then, of course, the FCDO, the Foreign Common Development Organization, also deprioritized health, which is the same as saying we have withdrawn. We have had Danida is coming to an end. So many donor or development organizations are ending. And I think Kenya must understand what I'm saying right now. And I'll come from the first point of health financing. We must have our own money to ensure all Kenyans have access to the highest attainable standard of healthcare. We must have our own money. Now, what we have done with the US is that instead of them having an abrupt disruptive stop the way they did on 20th of January this year, and that really affected the healthcare system in Kenya, we have agreed with them that, wait a minute, you are our good friends. We have been good partners in health. Why don't we have a 5-year framework? By that 5 years, if you invest in the things that we, the government, think are useful to make the healthcare system in Kenya sustainable, responsive, resilient, then now you can go. That is why the framework is for 5 years.
Okay.
Now, that 5 years, the US government has told us, okay, we understand. You said that we disrupted your healthcare system. We withdrew too early without a warning. Okay, right. Let's engage and let's sign a cooperation framework that in 5 years' time you will stand on your own. So the money is also not based on the fact that we are so much needy, or that the fact that we really needed aid. It's about, we have our priorities as a Kenyan government. We think that we will get there, but we are not yet there. We need a bit of a push and support. And the US is saying, okay, we are your good friends. We understand that when we stopped giving medicines and when we stopped paying healthcare workers, you are not ready. And by the way, I'll go back to that story because the USAID funded programs were supporting 42,000 healthcare workers.
Yes.
42,000. 28,000 of them that were directly in the hospitals. Yeah. 11,000 of them that were in the county, and another 2,000 in the national program. So 13,000 people that in just government places alone. So all of those people became jobless. So you can imagine the devastation in their lives. And
yes,
in
it was
the economy.
terrible.
It was terrible. I remember the first 1 week, because I was dealing with this. I was also the one in charge of that impact assessment. The first 1 week, we did not have nevirapine in the hospital. It's a medicine that is given to children. We did not have malaria medicine called artesunate. Not because it was not in the country, but because it was in the country, but the person who was holding it, or the organization holding, had a contract with the US government, and they were like, oh, our contract has been cancelled. Sorry, Kenya government, we have nothing to do with you. Okay? So these are the reasons why we had to re-engage with the American government. Say, okay, if you want to withdraw, it's fine, but let's do it in a way that also gets us to where we want to be. And so one of the things we have signed there, that Kenya will have attained the sustainable, strong, self-reliant healthcare system by 5 years.
Right.
And so that's the first thing about the time frame. Now, about the data, the reporting system in Kenya and the reporting system in the US requires that you do 2 years. So, for example, today, if I were to, right now I'm doing a report, for example, to Parliament. The report that I am doing is for the last financial year. Okay? So that is why we were, in terms of that accountability in the data, if I have given you money and you have spent it, I can only know that you've spent it in the next year. I can only know how many people got HIV, malaria, how much surveillance that you did in the next year. I hope you understand.
That's true.
And, so, and for me to audit that, then I have to even go 1 year further. That is why in the data sharing, we have put 7 years, because that is consistent with our laws here in Kenya. It's consistent with our PFM Act, the Public Finance Management Act of 2012. It's also consistent with the way we do our reporting. And it is also consistent with the way they do their reporting to Congress. So that is why we agreed we are doing 5-year cooperation framework, but because the data is meant for the implementation of the cooperation framework, we will do 2 years.
Where is this data
outside.
stored? Where is this data stored? Is it in Kenya's database?
I told you that one of our priority areas in the healthcare system is what we call digitization.
Digitization, right.
So in the digitization, we are implementing something we call comprehensive integrated health information system.
Okay.
And I'll just break it down. So what it means is that we have a pipeline. We have a data pipeline for the entire country. All hospitals and all data systems plug into that pipeline.
Yes.
And then at the top, we have what we call registries. So that is where we are storing all our data.
And does the US then, because I have to go quickly
yes.
with this data that has been digitized, does the US then, because you've just said across the country, all hospitals, all records, all people plugged into this, right?
That is a Kenyan government thing. That is not a US government
understood.
thing.
So long as you attend hospital, you then you attend hospital for whatever illness, sickness, check, you're in this system.
Yeah.
Through this deal with the US and Kenya, does the US have access to this digitized database?
They don't.
They don't.
And that is why we had to sign. And I'll say this in context. That is why we had to sign a data sharing agreement. You know, you don't sign for what you have access to. Why would I sign an agreement with you if I have access to what you're doing? I hope Kenyans understand what I'm saying.
So you're saying they already have access to it?
If they had access to it, why would they sign it? So the reason why they are signing it is because they don't have access to it. And I'll tell you two things that happened. So earlier this year, and of course after all of this stop work order, we consolidated all our data systems. We had a number of data systems. We had the Chanjo.ke where we are for the immunization. We had Damu for blood. We had Tibu for TB. We had the malaria. We had Kenya EMR. All of them, we have now brought them together. In fact, this happened when CS Dwale and myself came. We brought all of them together. And we brought all of them in the hands of the Kenyan government, hosted by the Kenyan government, secured by the Kenyan government, managed by the Kenyan government. Previously, what used to happen, and I'm not saying that is what was obtaining then, because Kenya had not yet invested in a comprehensive integrated health information system. We didn't have it. So I can't say that it was wrong then. But what was happening before is that through a USAID funded program, so the USAID would give money to an NGO. The NGO would go and say that, okay, for us to do all of this work, we also must have computers, we must have a system. Now, that is what was directly at the hospital level. I hope you understand. Now, all of that information, of course, the government was accessing it, but also it needed to be controlled, because remember that even the Data Protection Act just came in 2019. I hope you understand. But the information and the data was there even from 2013, from 2010. I hope you understand. So it means that this information was just available. So now is when we have consolidated it. And in the data sharing agreement, we are very clear that the provision of that data will be on the basis of the Data Protection Act and also the Digital Health Act of 2023. Now, for health, we have even gone a step further, passed a regulation on how health data can be used to make sure that every Kenyan has secured confidentiality of their information, and that every single data that we have, for you to use it, there is a reason why you have to access it and use it, and you have to give a feedback that you used it for only that purpose. And that is both in tandem with the Data Protection Act. And by the way, when we were negotiating this data sharing agreement, we wrote to the data commissioner, Madam Kasait, and she is on record that she was consulted and she gave the advisory, and she said what we need to do as a country to make sure that all Kenyan data are protected. And as I've mentioned, we will not get tired of saying this, but I think we just want to give the assurance to the country that we have done the very best to protect their data. And by the way, it's even recorded there that should there be conflict between the Kenyan law and the US law, the Kenyan law will prevail.
So, Daktari, you'll be sharing this data with the US. What would they be using this data for?
So,
since we are peers and we are comparing notes, is Kenya government as well able to get this data from the US?
Yes. By the way, it is also
from US government, just so you compare notes and see how to improve on each other. And as well, what will it take for Kenyan government to get that data from the US government to share?
So in the that's why it's called data sharing. Sharing, what does that mean? That we both exchange. So there are two sets of data. One, of course, is the data that is meant for the implementation of the programs themselves. How many people did we reach with ARVs? How many malaria cases did we treat? If we helped in terms of performance of hospitals, what was the improvement in terms of clinical outcomes from this number of people dying in a hospital to now this number of people that we've saved, and all of that. That data is important,
right?
Because it's what shows their taxpayers and their Congress that they have improved the healthcare system in Kenya.
Come the Kenya government
Now,
as
we
well.
are also getting the data, and the data that we are getting from them is about the expenditures, but also we are getting the data in terms of the outbreaks in other places. Because, for example, when we are doing disease outbreaks and surveillance, we are both strengthening the healthcare systems. And so if there is, for example, a disease outbreak elsewhere, the US government is also sharing with us that information. So we are also getting the data that, by the way...
But they're not sharing information, Dr. Harry, about people.
Yes.
They're sharing surveillance information. And I think we need some clarity on
but
this.
But even
Dr.
as we are sharing surveillance information...
I need to be very clear about this. Is information about Kenyans, 40-year-old... 6'4" Kenyan, having been treated at Kenyatta National Hospital for cancer records 1, 2, 3. Is information like that being shared with the US?
No.
Secondly, the information that we are talking about is just for reporting, accounting, and management purposes? We're saying
purely
that we
aggregate.
did surveillance in Migori County, for example, with this money that you have given to us. And based on that 1, 2, 3, it cost X amount of money, and here it is. So we're saying that this data sharing for the US is purely for purposes of accounting?
Purely. The documents are public. You can interpret them for yourself. Yeah. And so anyone can fact check what I'm saying. It's aggregate data from aggregate systems. What we mean by aggregate systems is that we are not going to go to a hospital in Migori or a hospital in Mombasa and saying this number of people came here, they are the ones that benefited from your services. Aggregate systems means that the system in Migori, the system in Mombasa, the system in Kakamega, the system in Nairobi, all of them put together. So you will not even know that this number of people were in Migori. You will know that this number of people were Kenyans.
Okay.
I hope you understand.
I understand
so
that.
Now that's aggregate systems.
Right.
Now, aggregate data, even if you knew that this number of people were Kenyans who benefited from this service, you will not know that this one was Oluga, he's 40 years old. No. You will know that we had 1.3 million people who got services, and by this time we have aggregated the performance that all of these people are well controlled, all this number of pregnant people got nets. It's aggregate data.
That's understood.
From aggregate systems, and it is very clear in the data sharing agreement. It is for purposes of implementation of the cooperation framework.
Okay, so
whatever
the primary
we have,
issue here,
yes,
the primary issue here is that there's a funding agreement between these two nations.
Yes,
that's the primary thing. That the US essentially is helping again with donor aid. It's donor aid. That's what it is.
This one is a partnership, but
it's a partnership.
So, because we are also putting money, and it's tied together.
Kenya is putting money in this deal.
Yeah. Kenya is putting.
Is any of this money going to the US?
No. Kenya is putting in money for. By the way, the US and let me explain this. So the US also have their diplomatic priorities, and the US also is interested in protecting their own health.
Yes.
And I can tell you for a fact, the reason why the US is also funding disease surveillance and outbreaks is also to protect their own health, so that they protect the diseases before they come, some to their borders, but also so that they know how to deal with them. So it is also in their best interest. And so I think one of the things we should not misconstrue is to say that, no, this is lopsided, it's just Kenya. No.
This is what my question was, so maybe you can answer in that direction. So if we're saying this is development aid,
it's not development aid. It's not charity.
It's not charity.
Yeah.
Okay.
It's a
so
partnership.
the US are looking to protect their systems.
Yes.
Whereby they ensure that any diseases that could potentially come to them are found out. Right. They're putting a significant amount of money. If Kenya's putting in some money, that money is staying in Kenya. If that's the case, why is it called a data sharing deal as opposed to then a funding deal whereby money is going in to protect health systems for Kenya?
So now we have the cooperation framework. Now the cooperation framework looks at what exactly are we going to do, how much money are we going to put in both countries together. So that's the funding deal.
Yes.
The funding deal is the cooperation framework. And by the way, this is not new. Even USAID signed something called Development Cooperation Framework in 2021. So it's not a new thing. So the cooperation framework is the funding deal. Now, under the cooperation framework, there are three things that are important. One is how you will implement it. That we are yet to determine. So we are now going into what we're calling an implementation matrix. Okay. Number two is the finance agreement. So you do a funding deal, but then you have to do a finance agreement. The finance agreement is now what puts this money into our budgets. Now that is done by the National Treasury. That is currently ongoing. And then three is the information that comes from this our corporation, because we will be doing things together. I'll be sending you money. I'll be investing in your hospitals. I will also be putting in money. We will share the information as far as disease outbreaks are concerned. We will be doing all of this work together. And you have taken over all the systems. So how do I know what you're doing? So you have to share with me the information. And we have a Data Protection Act. So the reason why we were going into the data sharing agreement is because the Kenyan government right now has full control of the entire ecosystem of data. And so the US like, no, wait a minute. So I'm going to do all of this. How do I know what you're doing? So then we had to go into how I'm going to share that data in a way that is consistent with the Kenyan laws. And that is really what we want to tell the country, that the data sharing agreement, which is now public, is meant only for the implementation of the cooperation framework. It does not go into other health areas that are not part of the cooperation framework.
So, Dr. The funding is there. The data has been shared. It is with the US government. But question then is, who is conducting oversight on how this data is being used by the US government? And what guarantees do you have to give people of Kenya that the US government will use this data for the benefit of Kenyans and will not misuse it?
So within the data sharing agreement, there are four mechanisms that we've clearly put there. Number one, of course, is that there has to be a request. So it's not just that, there's data sharing agreement. Okay, what did we do together? Here it is. No, you have to request me in terms of what we call covered data systems. It is there in the agreement, covered data systems. So we will agree on the covered data systems. Agree means that you have to request me. Then we have to agree, okay, this covered data system I'll provide for you. Number two is that there has to be approval. So now we have approval at the Digital Health Agency, which is our new institution of looking at health data. And then we have another approval at the Data Commissioner, which is the one that deals with Data Protection Act. And there are also regulations. Number three is that you have to use it for the purpose for which you requested. And number four is that you have to tell me that you used it only for the purpose that you request. And it is there in the law, in that data sharing agreement, that should you use it for another purpose, then you have breached the contract.
How will you know? How will you oversight to ensure that?
We will oversight because, this information, first of all, it's aggregate and it is from aggregate systems. Now, when you tell me that I will use this information only for this purpose as a government, we have ways of checking.
Okay.
Yeah. And that's the sharing that we're talking about, because there is three processes. One, the performance. So the performance audit is also related to the data, the performance of what you use the data for. So if you read some of the articles there is the thing about the data use. So when you talk about the data use, it tells you what you have to use it for. If you don't, then you have already breached the law.
Okay.
Yeah. And of course, there are mechanisms in which we are going to deal with such kind of
So
issues.
what can they use it for currently? What this data that's been given, which you had talked about for accounting purposes and such, what else, according to this deal, I mean, we've looked through it, but what else, according to you, can they use this data for?
I think we have to be fair to the US government. One is that we have had a very long relationship with the US government, 50 years. And it's not just in health, it's in many areas. And they are our greatest partners. In fact, the largest single bilateral development organization we have is the US government. So we have to come from that perspective that we've had a good relationship before. If you've had a good relationship before, there is already inbuilt trust. Now we have even gone further than the relationship to do a document. we've never done that before. So if it's like you've been girlfriend, boyfriend for quite a long time, you've been good, and then now you have a marriage certificate, So it makes it even better and firmer. So in terms of what they can use it for, we use it for the things that relate to the implementation of this framework. What are those things? They have to, of course, justify to their taxpayers. They have to justify for their Congress. They have to know that the Kenyan healthcare system is moving towards the direction we told them. I told you that the premise upon which all of this is that, okay, us as US, we want to withdraw. We no longer want to fund you. Then Kenya government says, okay, wait a minute. You are financing us. You are financing us through a mechanism that was not government to government. Now I have put in a strong system that I think is now going to make me stand on my own feet, so that in the future I may not need this kind of hand-holding. But before I get there, let's work together. So now change what you have been doing here through other people that are not aligned perhaps with what I am doing as a government. Now let us do this thing that I want as government. You invest in my SHA, invest in my KEMSA, invest in my surveillance through the National Public Health Institute. Let my institutions be strong so that I stand on my own. When I get there in 5 years, I think I will be there. Then now you can walk out. So let's start from the fact that they wanted to withdraw. Okay, so now they have to also monitor that, okay, so you told me that if I gave you this money, you are getting there. So are you actually getting there?
Okay.
So they need that information.
Yeah.
So if you say that right now you have 59,000 new HIV infections and you want to do more prevention, okay, so next year, are the number of people getting HIV infections less?
Okay.
So they have to, it's
That's
just
interesting.
there.
So then on the Kenyan side, let's just, and I think this document is a public document because folks are asking, is this document public? It's public.
It's public.
Been shared and everything that was in this is there.
It's public.
People ask questions about public participation and things like that. But let's look on this other side, whereby you've talked about that in 5 years, the things Kenya should essentially be, number one, independent, and number two, and I'm talking about independent in this space whereby its health issues can be taken care of by Kenyan money, and that money actually be applied to these processes. What is it going to look like in some time when this money is actually applied? Let's say now part of this money is applied to the health system, and I'm talking about brick and mortar things.
Yeah.
You were at the NMS when we saw in Nairobi 24 health facilities, plug and play facilities were built at the cost of about 800,000 shillings, and that people were able to go into level 2s and 3s and actually get things done. You and I can say this publicly, you and I personally worked on a case where a woman had to have treatment at Kenyatta National Hospital, and we had to wait for months for her to get a scan because there was only one machine and the lines were very long. These are real situations, Dr. Terry.
Yeah.
What will happen for us to see a change? Because that has been the problem for the longest time, that there can be a loan that has been taken, there can be a grant that has been given, but we don't see the physical manifestation of it in country. What will start to change that we can say, okay, we can see that this American money is being applied here, and we can actually see changes in the health system. You know who's crying? Teachers are crying already about their new system because they say, where are we going to go to get this health facility when the next one is how many kilometers away and I'm supposed to be in school teaching? Those are the real situations. Mothers cannot get out of hospital. They're held because the bills have not been paid because there's not enough money to go around. Real situations. So how are we going to see that money is going to translate to the situations that are plaguing society today? Will it happen?
It will happen. And thank you so much for bringing us to the reality of our healthcare system, because we can discuss all of this money is around 208 billion about Kenya going to put in another 50 billion about the data, but then we forget the people. And I think from where you have left it, I just have to say three things. One is that what is it that if we do with the money, we get there? Now, what is it that if we do with the money, we get there? Number one is that we have to look at what we call revenue measures, because we want to have our own basket of money to be able to pay for healthcare. The reason why you say people let's say they get stuck in a hospital, it's because they have not, for example, registered for the Social Health Authority. Why have they not registered? Is that they didn't get the information? Is that they didn't have the money? Or is it that they refused? So those three things are important in terms of where do you want to go and how do we get the money. So that is the first thing that we want to invest in terms of strengthening our Social Health Authority. Now, strengthening our Social Health Authority means that the things that the Social Health Authority cannot pay for now are the things that we are going to start looking at. How does this money get to the Social Health Authority so that it pays for it? I hope you understand what we are saying. And then within that 5 years, we work with the Kenyans so that they are able to pay their contributions to the Social Health Authority. So that in another 5 years, the Social Health Authority has the money to pay for the thing that we used the American money to pay for. So for example, if today we say that we are investing in maternal and child health care, and you've said some women getting stuck in hospital, we will have to determine, so these women who got stuck in a hospital, because right now you're not supposed to be, even as we speak, even without the US money, you're not supposed to be stuck in a hospital, because we have made it very clear that all hospitals are covered. But then you find, and I got this case in Nairobi, and I have to mention Mama Lucy, because first of all, I worked in Nairobi, so I know Nairobi very well. I have been in these hospitals. I know the healthcare system here very well. And so you find ladies who are in Mama Lucy stuck after delivery. The reason why they were stuck is because they have not registered for the Social Health Authority. The reason why they have not registered for the Social Health Authority, we found out that 3 of them did not have IDs. So they are over 18, but they did not have IDs. So, you know, these challenges, and I think Kenyans have to work with us so that we all develop the country together. So we've already said that you will be paid for maternity, but you as a Kenyan, you have refused to join, or you have been hindered to join because of some other issues. Maybe you didn't get the information, but the information is there. So these are the things we want to work for. So how do we make sure that everyone coming to hospital, people have IDs, they have registered? There are also those people who cannot pay or won't pay because they are very poor. So those are the things we want to look at, the sponsorship programs like the one that the president has started. So we want to invest robustly in those things. The second thing that is very important with this money for us to get there is when you get to the hospital, does the hospital give you the services that you need? We call that the health system's performance. So we can work on the Social Health Authority, we can work on the revenue, we can work on every money that we need to pay for the services. But are the services available? It's like going to a hotel. You have 1,000 shillings, you can eat lunch, but the hotel doesn't have the food. So the second thing we want to work on is, does the healthcare system help you to get those services? So that's why we want to invest in that. We want to invest to make sure that the machines are working. We want to invest to make sure that the worker is there. That's why if you look at that, our cooperation framework, which is public, you will see there health workers. We want to take 13,000. Why? Because we don't want you to wait longer. We want to work on commodities so that you have the medicines that are there. We want to work on hospital equipment. We want to work on laboratories. By the laboratory is one of the biggest there. We'll be investing in over 52 laboratories so that we can give you the diagnosis you need.
Daktari,
do you get the services that the hospital can offer, even if we can pay for it?
Daktari, one of the major problems that has existed for a very long time in healthcare in the country is graft and corruption. Whether we have the US funding.
I wanted to get that on the third one.
Okay.
So the third thing is, we have the money, the hospital has the service, can we sustain it? Like, can all of those things work in an arrangement that we are sure that tomorrow it will still be sustainable? So what does that mean? It means that we have to prioritize. It means that we have to utilize the money efficiently and effectively. It means that we have to put mechanisms for accountability. And accountability is not just accountability for money. It's accountability for, did the doctor come on time? It's accountability for, did the CEC or the chief officer do the work that they are meant to do? If they are meant to do a return so that I pay the UHC workers in time, did they do it? So we also want to invest in that system of sustainability. That system of sustainability has a framework of accountability in there. That accountability, there's social accountability, there's professional accountability, and you want to invest to ensure that whether it is at the leadership and governance, whether it is at the management, or whether it's at the service delivery level, there is a sustainability framework.
Okay.
Now, those three things are what will get us to the Kenya that we are now telling the US government that, okay, in 5 years, we are where we are supposed to be. We can now sustain our systems. We can pay for our TB services. We can pay for malaria services. We can do surveillance for our own systems, for our own disease outbreaks. Revenue first, in terms of the money we need, Social Health Authority. The health system performance. Does the hospital or the healthcare system give you the services that you require as a Kenyan? Number 3, can we make all of these things work seamlessly? Can we be assured that tomorrow, what we have done with this money can still be available? How do we do the sustainability?
And that's what needs to be followed. I mean, an hour is not enough to go through some of these things and interrogate some of these processes. But that the things that you said, that we will see them in reality,
We will
is
see
what
them
the
in
hope
reality.
is. And of course, it continues to be discourse, but then it continues to be hope that we actually live them out and see them be. Dr. Ouma Oluga, thank you for coming. Thank you for being here this morning. Principal Secretary, Medical Services, the Ministry of Health, going through a lot of these issues this morning, necessary that we do.
Thank
we
you
look
so
forward to a
much.
time where it can be actually seamless and simultaneous.
We've made progress, Lou. We've made progress, Dennis. Kenyans, we've made progress. We are not where we want to be, but we are firmly on the path to where we want to be.
Asante sana.
Asante.
This is the Situation Room, the only way to start your day.